Welcome everyone to another episode of The Corrected View. I am so excited about tonight's event. We have a really cool format for any of our sports lovers. We're going to do this PTI style. So we're going to have a bunch of different topics that you can see on the screen right now. And we're going to go just quick fire, go through it, debate style. We have Dr. Dwight Barnes joining myself, Anith Pillay. And again, Dr. Amazing Matthew Martin for part two.
You just couldn't Matthew, get enough thanks for being with us again, man. What's new in your life?
It's going to be a good time.
I have been waiting for this for so long. I'm so excited, and these are like really hot topics. So I can't wait to delve into it.
Briefly, let me give you guys a little bit of an explanation on how this is going to work. So if some of you guys have watched the ESPN show, Pardon the Interruption, abbreviated PTI, it's got Mike Wilbon and Tony Kornheiser, and they do this great back and forth where they'll have a list of topics for the day. They'll have an order that they're going to go in, and they'll have a certain amount of time for each topic. So it keeps it moving. And a lot of these are things we could talk about for a half hour, but we will not. It'll be a matter of just a few minutes for each topic. And that's for all three of us. So we haven't done this before. We're going to find out how it works, but we'll run through, we'll throw the first topic out there, and you can follow along with the list there. And we're going to have a clock up, and we'll just try to get through as much of it as we can. And like Anith said, these are the hot topics that we could identify in myopia management and optometry right now. So I think it will be a fun little back and forth debate.
Oh, I can't wait. Before we get started, just in case anybody didn't see part one with Dr. Martin, you want to just give a quick intro, tell us a little bit about yourself and your practice, and then we'll dive into it and just go after each other.
All right. So my name is Dr. Martin. I am really excited to be on this evening. I've been practicing Ortho-K for about 21 years now. I've got patients who've been at it for 19 plus years. I do, Ortho-K, atropine, peripheral defocus contact lenses. I love it. Deeply involved in myopia management, and I'm very excited to have these conversations because when we go to Vision by Design or some of the other meetings, these conversations happen all the time. And I love how it's back and forth and people get their opinions and it gets hot and people are like, this is the way I do it. And I'm like, well, that's fine, but my way works better. And I think it's going to be really exciting. So I'm really happy to be here.
Thank you so much for joining us. And you just delved us right into the first topic. You said you're really big into myopia management. So Dwight, let's get into it.
Let's do it then. All right. So we got a different amount of time for each topic. We got 3 minutes on the clock for the first one. So we're going to start that timer right here. There's been a lot of debate. Do we call it myopia management? Do we call it myopia control? Is one better than the other? Are they both the same? Does it not matter one bit? Anith, what do you think, buddy?
Hey, probably my view has changed actually. So about 2 years ago, I was big on myopia management, and I think a lot of doctors were going that way. And probably last year, I changed my idea, and I was like, no, definitely myopia control. We're AOMC, the Academy of Myopia Control. My site got approved for myopia control. I really don't think there's any reason to say myopia management. I think there's a lot of evidence that we are controlling it. So I am definitely on the bandwagon of now myopia control. If you look at SEO and keyword searches, myopia control is searched usually a significant amount more too. So just from that aspect, from practice management, I think myopia control is not only beneficial clinically, but also on the practice management side. So I'm definitely pro myopia control.
All right, so I'm your myopia management.
Matthew, what you got, buddy?
All right, I'm your myopia management guy, and here's why. I had this discussion with one of the major players in the industry, and here was their argument, and I think it was a very cogent argument. The only lens that's been approved for myopia control is the MiSight lens, okay? So technically, when I'm speaking on stage, when I'm lecturing, when I'm doing something for any type of professional thing, I should be saying that the only device that's been okayed for myopia control is the MiSight lens. So that means Ortho-K, peripheral defocus contact lenses, low light therapy, all that other stuff is myopia management. So I view it as myopia management as a group of things that we do to manage the myopia and the progression. But technically, the only really legitimate one for myopia control is the MiSight lens.
That is
so I think you can make the argument that we are controlling myopia when we do those other things as well.
That is a very accurate argument. I'm going to come down on the side of, I think it's semantics and I use both of them. On one hand, I'm a big fan of alliteration and myopia management really rolls off the tongue. On the other hand, before this argument ever came up, I told people I practice myopia control, and I've labeled the section of my clinic that deals with that our myopia control clinic. And I've been calling it that long enough that I don't think I'm going to change now. So I don't know that my answer is as eloquent as Anith or as accurate as Matthew. But in my case, I actually use them both interchangeably, although there may be some legalese with FDA approval that would stomp on some of my recommendation. But I use either one of them, and I honestly don't even care.
So my worry is that I'm going to be giving a lecture for somebody or on stage for somebody, and that I will misspeak and grab control instead of myopia management. So I just kind of decided myopia management was a better way for me to go.
I can see that maybe on a speaking stage, but I would say the reason that MiSight got approved for myopia control for peripheral myopic defocus is the exact same mechanism of action that we're using in Ortho-K. So the reason that it got into it, it makes it reasonable for us to say myopia control for Ortho-K as well. And
ding, ding, ding.
You can toss it up.
100% correct.
All right. That was good. Let's move on to our next topic. We got 2 minutes on the board. We're talking about PrepareCane or not. And what we mean is when we are putting on a mold in the office, the first time a patient's going to experience that mold or that lens, are we using a numbing agent for that? Matthew, what do you think, buddy?
I am firmly in the PrepareCane camp here. Maybe I'm an old school guy, but I like PrepareCane. I like the fluoresce with the PrepareCane in it. And when I'm putting that first initial evaluation of that Ortho-K retainer on a patient's eye, I don't want them to freak out. And I just find it's a smoother, easier process for me. And then it allows me to transition them into actually wearing them going forward.
Aneth.
Yeah, I see your point, and I'm a little different because I don't apply it at the first day. I do mostly software-based design, so I'm ordering it, we dispense it, they wear it at home, and then I see them the next morning. So it doesn't really come into play. But if I am applying a retainer, and I love the fact that you use the word retainer, then I probably do the fluoresce because I get 2 birds with 1 stone. Get the kid calm, get the fluorescein in there as well. If anything that can make the process smoother is better for me. I know a lot of doctors that say, well, if you're using PrepareCane, you're not giving the true sensation and what's going on. Yeah, but that's all done at home. My thing is I got to get them in and out. I want to get my measurements and see what the fluorescein pattern looks like, get the overrefraction and out. And that actually happened today when I was making design changes. But if I were doing a initial dispense visit, I probably would, just to make it quicker. I don't know how much and Matthew, I'll feed this back to you, how much PrepareCane really helps because a lot of the lid interaction and, sometimes just the kid's apprehension, I don't know how much it really helps. I feel like just having the proper lubrication goes a long way too.
Well, I've done it both ways and I'm a PrepareCane guy. So that's kind of where I fall in that camp.
And I'll jump in there. I'm a PrepareCane guy as well myself. The argument that you'll hear sometimes is that it's cheating with the patient. It's not giving them a real sense for how it's going to feel. But PrepareCane does not 100% numb the eye. Most importantly, though, if I want to evaluate that fluorescein pattern, I would rather them not have so much reflex tearing. It washes out the PrepareCane. It makes the whole pattern a little messier until you leave it longer. The thing's going to settle easier and quicker. So it's easier for me and it's easier for the patient too. I'm pro PrepareCane.
Here's one thing I'll say, that usually the only time I'm putting the retainer on the eye is usually at that 2-week visit if I need to make a change. And at that point, I don't use PrepareCane. They should be
fair enough.
Fair enough.
Yeah.
Ding, for me, it's an initial visit.
Ding, ding. All right. Sorry about
I agree. Yeah, initial visit. All right. So the next one on the list here, it comes right in from that last one because we had some differences in how we do things with an in-office diagnostic application of the actual retaining mold. So we can hit on that. Is that something that you do? In-office diagnostic application for evaluation, demonstration of vision improvement, or just to assess the patient reaction versus just do everything empirically? Anith, it's back to you. What do you do?
Oh, I am 100% empirically. I don't do any in-office diagnostic evaluations. I do see some benefit of it from a practice management perspective, where if you put a retainer on the eye, let the kids sleep for 20, 30 minutes, and then parents can see, wow, they already lost 50% or whatever. I get that portion of it. I haven't had to need that in my practice, but everything that I do is completely empirically. We do software-based designs. get them in, get them out. I'll see them back after the first night and then 2 weeks later.
Okay, so for me,
Matthew.
I'm an
Yeah.
in-office diagnostic guy. I do a lot of empirical fitting, but if I've got a spherical cornea and I want to take a look at just a simple spherical design, I happen to have lots of fit sets over almost 20 years of doing this. So a lot of times I'll put one on the eye when I'm doing an evaluation or doing the discussion on Ortho-K as an option. And when I can fit that child during the talk with the parents, child takes it out, they're seeing much, much better. Sometimes down to 20 parents are sold. It really works for me. Dwight?
Yeah, I do the same thing. If that's the old school way of doing it, you can count me in camp old school, Matthew. I started doing it because that's the way I was initially taught to do it. I don't know that it's important now because I do, again, software design like you guys do. You know, the mold that I put on the eye is not going to be the same one that the patient ends up actually getting.
Yes, and I explained that.
I do think showing the magic to the patient and the parents can be beneficial, as you said. I think that can be a practice builder. And the other thing is, sometimes kids are anxious and they get over it really quick and they do great. Sometimes they stay anxious and they really struggle. I want to assess the patient. And when you put that mold on the patient, you can tell how comfortable they are with the process. Are they kind of freaking out a little bit? Are they settling down and saying, oh man, I got this, I can do this? I think that's valuable information as a practitioner. So I enjoy getting that information.
Oh, come on, guys, get out of the old school. Give away your flip phones, come into software-based designs. You'll see them the next morning. You'll see the magic then.
Fair enough. Ding, ding. All right, we're going to move on to the next topic. We have all used different words to describe these things that we are putting on eyes when we're doing Ortho-K. So the question is, are they contact lenses? Are they retainers? Are they molds? Are they reshaping lenses? Or are they something else altogether? And Matthew, you get to start us off on this one. What do you call them and why?
Good, because I have strong opinions here. I call them retainers because I call them retainers because I want patients to know it's not simply a contact lens that you're going to go to 1-800 contact lenses and order. That's not the way this process works. It is a retainer, and the goal is to retain the quality of your vision and slow down the progression of your myopia. And that's the way I view it. I really like the term retainer. I like it better than mold because I don't like the idea of mold in the eye. It just doesn't do it for me. And I definitely don't like the idea of calling them a lens because I think it devalues the concept of what we're doing. I think people are like, well, I can get a lens anywhere, right? And I want them to be like, I'm in a program here. I'm in a myopia management program that is specifically using an Ortho-K retainer to help me to be better.
Well, I hate to agree with Matthew here, but I'm a little biased because I got the word retainer from him. First Vision by Design, when we're talking, I stole that from him. So that's the reason I call it retainer as well. And it's what I've been doing for years now. I'm okay with mold. You know, I actually don't mind that term. I think it's a little easier to say a corneal mold versus retainer because I do feel patients sometimes revert back to lenses. But in our office, I really hate when our team members say lenses for the exact same reason Matthew said. This is not a lens, not a regular contact lens. It's not something that you can just get anywhere. It's a whole process. It's a design. It's a program. It's a treatment. More than anything else, it's not the matter of just the plastic. So I use retainer in my office. I'm okay with mold, but the biggest thing is don't call them lenses.
Yep. And I agree with you guys. I use a different term. I use mold, so I'll be the dissenting opinion here. But I think where the agreement is kind of anything but a lens, or especially anything but a contact lens, right? It creates the concept that it's a commodity and it's anything but a commodity. We all know if you have two patients come in and they're both a -3 sphere, they're probably not walking out of your office after a dispense visit with the exact same design and the exact same parameters because their corneal shape is different and things like that. And there may be different ages and have different needs. So I like the term mold. I do think it's easy for patients to remember. My patients still call them lenses sometimes, and I don't correct them. I just continue to make sure I use the term mold so they hear that from me. And like you said, and try to make sure the staff continue to do that. But anything to eliminate that concept of it being a commodity, something that they can buy off the shelf. And
I think it's important. Well. I think it's important to stay on message. Like the whole staff needs to be on that so that they know it's a program. It's just not something they can go to the drugstore and get or something they can pick up at Myers. It's a program, and that's the concept. We'll be talking about programs in a fashion, and I'm totally in it on that.
All right. I think we got it. Well, ding, ding, ding. We did okay on that. So We're gonna get started with the next one, I believe, is a 2-minute topic. So the next topic is axial length. Axial length is a hot topic. It has been for 2 to 3 years now, and it continues to be. Should axial length be our primary outcome when we're talking about myopia management or myopia control, whichever of those words you consider, or should it be something else? And this is your turn, Anith, to go first. So tell us about that.
Yeah, I would say probably the first 3 to 4 years of doing myopia control at our private practice, I didn't have an axial length machine, and we were monitoring it by refraction. And I was like, how much do you really need it? Since we brought it on, oh man, I can't imagine going back. I think it will eventually become the standard of care for myopia control. I think it is the way to track it. I think it's the most objective measurement, and we can talk about what is your criteria of progression, right? I like to be a little aggressive. It does change by age, but I like nothing more than 0.02 millimeters a year. So if I see something more than that, then I'm like, okay, I need to maybe change my ortho-K design. I need to add combo therapy, whatever it is. But that has changed the game. It is equivalent to adding OCT in glaucoma management. That's how I think of it.
You completely stole what I was going to say. 100%.
I was not that guy several years ago. I was like, you don't need it to start myopia control. Now, I still agree you don't need it to start, but if you're getting into it, if you want to be the guy in your community for myopia control, I think you got to invest in some type of axial length measurement, because it's going to change the game. Because every now and then you might have a patient that changes by -0.5, and maybe they're just over accommodating, and they're kids, for God's sakes. Who knows what the refraction is going to be, right? Who knows how they're going to react about it for optic. But that axial length is an objective measurement that's, with the instruments that we have nowadays, super repeatable, super accurate. I wouldn't go back.
So Matthew, go.
I think he's 100% correct, because I am.
You ever get tired of saying that it's 100% correct?
Completely sold on axial length. I have been. It is the OCT of the myopia management. And if you don't have axial length measurement consistency, that is as far as I'm concerned, it's becoming my be all end all. I don't even talk that much about refraction, because it really is coming down a lot for me about axial length. It is an objective measurement. I can look at it. Your child is advancing despite the fact that we've got him on atropine. We're going to add ortho-K. Your child is doing peripheral defocus contact lenses. And I think we could be doing better. We're going to add atropine. I think it is where everyone is going to be. If they're not already, they're going to head that way.
All right, and I'm going to jump in, even though the bell already rang. It's ding ding, but I get to talk too. So we got like Anith was saying, you got to have a criterion, right? What's an acceptable amount of change and what's not? I think we're all in agreement that this is where the field is going, and if you're really serious about it, you should try to be there now if you can. And I am always a big proponent of do myopia management if you can do it, and if you don't have a way to measure axial length accurately, do myopia management anyway, because you're still going to help kids. But it is a game changer. Like you said, the OCT, the glaucoma, what have you, it's a huge game changer. And the other thing I'll mention on it is it's also the most important outcome in terms of what we want for these kids. It's not a matter of we want the kids to not have thick glasses, although we would like for them to not have a thick glasses prescription. We want their eyeball to be shorter so they don't get retinal detachments. We want their axial length to not go beyond 26 and hopefully to stop well short of that. So that's the whole idea of identify these at-risk patients early, measure axial length early, measure axial length often, and it lets you track them more accurately to keep those axial lengths shorter and keep those eyes healthier.
And when I talk to patients now, I talk about length of the eyeball. I talk about refraction after I've spoke about length of the eyeball. I just did this afternoon on a atropine myopia management visit with a new patient today.
I know we're going long, but I think it's important. There's one last question. I know I mentioned 0.02 is kind of my guideline. I don't know if you guys go by age. Do you have a threshold of what you'd like to see on a yearly basis?
Sure.
I'm a 0.02 guy as well. I think you and I are singing from the same hymnal there.
Yeah, I'm close to that. I'm 0.02 under age 10 roughly, and right around age 10, I actually like to see 0.01, which of course the less the better, right? I'd like to see 0.005, but yeah, 0.02 under 10 years old, and as they get up into 11, 12, 13 years old, I try to go a little bit less than that if possible.
Yeah.
All right, let's jump on to the next topic. This one actually gets a whopping 5 minutes. We'll see if we use all of that. Structuring your myopia management program. So the 3 different versions that we'll see sometimes is, one is a global fee, right? There's one fee the patient pays that covers everything that you do. You can do a separate fee for the molds and the evaluation, or you can charge per visit. And let's see, it is Matthew's turn to go first. So Matthew, what do you like?
I'm so glad you let me lead on this one. I have strong opinions here too. I believe that you're selling a myopia management plan, and I think a global fee is the way to go. So I've done a lot of research on this, and if you look at things like gym memberships, if you look at those types of concepts, when you sell a membership to somebody, you oftentimes get better buy-in than when you nickel and dime somebody. If you nickel and dime somebody all the time, they get to thinking, do I really have to continue to do this because it's costing me, okay? But if I say to them, I want to collect your money up front, we're going to do this myopia management thing, here are the visits, here's the follow-up, here's what we're going to do. The pain is once, the benefit is long-term. I think that's a much better method than, you got to do a measurement. Well, I don't want to come in for the measurement. Well, I don't care. You have to come in anyways. Well, I don't want to come in because it's going to cost me X amount of money. I don't want that. I want the initial pain of the cost to be out of the way so that they can follow the program without feeling the pain of having to come up with a chunk of money every time they come in. There you go. That's my thoughts on it.
So does that mean, like, what happens subsequent? Like, are you doing monthly for the lifetime of the treatment? Like, if they're a 10-year-old, they're monthly paying till they're 16, or is it just year 1 you pay this much and then every year it's whatever it is?
I'm a yearly program guy, so we've got a yearly program. There's visits involved. We have that set up for peripheral defocus contact lenses. We have it set up for Ortho-K. We have it set up for atropine. You know, I'm going to see you, every 3 months for axial length measurements. It's a quick visit. It's like a 5-minute visit. I'll be seeing you at the 6-month mark for your Ortho-K. I'm going to be following you. I mean, I like having a program that's structured, and I just really dislike the idea of nickel and diming, because it just seems like when I've done that in the past, it was horrible.
Got it. Yeah. So I'm a global fee guy also. Now, I do offer in-house financing, like meaning that I'll let them finance it monthly if they want, but it's all at once for the first year. And then we just have a lower fee for, subsequent years. And yeah. I'm the same way. Like, I want to include everything. Like, listen, this is an investment on your part, but this will include everything. I mean, this will include every visit you see me. This will include the retainers I give you. It's include any changes that I make. A couple of years ago, I would actually charge them extra, like, hey, you got to buy the solutions and whatever artificial tear you're using. And, I didn't get a lot of pushback on it, to be honest, because it wasn't that much. But then I was like, you know what? Why don't I just include that too? And hey, I raised my fees by 50%. That covered it by a lot, obviously. And then I'll cover broken retainers if they lose them. I don't want them to worry about that. I looked at my stats and I was like, what percentage of my patients are losing or breaking retainers? Because 2 years ago, they'd have to pay for each one. I'm like, you know what? I don't want you to worry about that. The first year I'll cover it. It was about 20% of patients would break or lose a retainer, and now I'll just cover it. And if 20% of my patients do it, and I raise my fee by 50% for all of my patients, I don't have to worry about that. I'm not in the business of selling retainers. I'm in the business of doing myopia control. All right.
I get you. And I agree with you. We do a global fee as well.
Last thing real quick, right, is I charge the same for all myopia control treatment options. Regardless if you're doing peripheral myopic defocus, regardless if you're doing atropine, regardless if you're doing Ortho-K, the price is the same. That way, I'm going to choose whatever's best for you. That way, price is not even an issue on the type of modality.
You charge the same fee across the board?
Across the board.
And then I have a question for you, Anith. So we're going to come back to you on this, Anith, for a second. I also do a global fee. I do it pretty similar to how Matthew does it. It's a yearly fee. We go ahead and collect it all up front. It's one fee for the first year, and then of course it's a little lower for the subsequent years if they're doing Ortho-K. And I try to present it as it's like Matthew said, it's a myopia control program, right? The Ortho-K or the MiSight lens or the atropine that we're using, that's just the tool we're using to achieve this. Right. But the main thing you're getting is the myopia program. Before we move on, because we got some time left, Anith, so I've heard of other practitioners doing the same for every treatment, and I don't. I do like the simplicity of the concept, When you do something like, let's say you have a patient who's going to do atropine only. I'm assuming you have some patients here and there that do atropine only.
Very few, but yes.
Do you supply the atropine from your office and that's included in the program, or do they get it from a pharmacy elsewhere?
I tried the supply method. It became a nightmare. It was tough. So now I do not.
Because that's the big sticking point for me. You know, the peripheral defocus contact lenses can get a little bit expensive on their own as well. And so those fees, you know, if you just kind of work them out, can come in pretty similar. But if you're not supplying the atropine and you're just charging for the visits, basically, you know, kind of as a global fee, that's where it got a little sticky for me. But you find that it's accepted okay by patients?
Well, here's the thing. So I do very few atropine only patients. This is a personal philosophy for me. So if I can avoid a medication, I try to. Not to say that atropine doesn't have a lot of studies showing its efficacy and safety profile. My personal opinion, I don't typically do atropine as a first-line therapy. Now, even with that, sometimes you have to use it, but I have probably, count on my fingers, how many patients I've done atropine alone.
Okay.
Now, let's say something's not working and I add atropine. I don't double the price. I include it. I include it, but wherever they get their atropine, that's outside of me. That's up to the pharmacy.
All right, ding, ding, ding.
The fee is for my time, my measurements, me taking care of you more than anything else. And
I love it.
With 95%, probably more, maybe 98% of being in the other two modalities, it has an effect.
All right. Well, moving on. So the next one's a big one, and it's been on the Google chat that we do, the thread there of topics there. Allowing patients to use a vision plan. Never, ever, ever. Yes, always. Okay for the molds, but not for the professional fees. Okay for sometimes, not for others. Anith, you can start us off. What do you think about vision plans in the realm of myopia management?
Well, we got 5 minutes. I'll leave this up to you. No.
Fair enough.
I'm
short
done.
and sweet. Matthew, tell us what you think.
I'm horrified by the idea of allowing vision plans into myopia management. To me, it's an anthem. To me, it's the absolute wrong thing to do. So as far as I'm concerned, absolutely no with the vision plans, and here's why. In my office, we used to get paid X amount of money for an exam back in the 80s or 90s. You know what? We're still getting paid that money for an exam because of vision insurance plans, right? Every time we use a vision insurance plan, they pay us less and less and less every year and still expect us to be able to do the things we need to do to make our patients happy. So what offices do is they cram patients through, they're cutting corners, they're not doing a good job because reimbursements are so low. If you invite vision plans to take over myopia management, it's going to get to a point where the pay is not commensurate with the amount of work and equipment and all the things I have to do to be a good caregiver, that all I'm going to be doing is not enjoying what I do and not being successful with what I do. So to me, it is the worst possible outcome. And every time I see someone who's pushing for it, I want to just scream at them. I have to hold myself back. I have to delete that email message because I want to grab them and go, what are you thinking? Nobody ruins optometry like optometry does. Nobody.
I do got one thing to say. I got one thing to say. If a vision plan were to cover myopia control options and reimburse properly, I'd be all for it. Win for us, win for the patient. That has never happened in the history of vision plan reimbursement. So that's why I think we should never invite them, because they're never going to reimburse what this treatment is worth. And then once you start inviting them, and then their reimbursement is what, 20, 30% of what we actually charge now?
Yep.
That's a slippery slope. So that's the reason. But if they reimburse what we charge, I'm good with it. That's fine.
Yeah, but well, the thing is this.
Concerned with that. And
the thing is this. If they pay X amount, here's my problem with vision plans. If they're going to pay me X amount this year, next year they're going to look at it and go, you know what? We're going to give you X minus 20%. And then 2 years later, it's X minus 20 more percent. And eventually what's going to happen is I'm going to be doing all this work I have to have an axial length measuring device. I have to have a high quality topographer. I have to have all this fancy stuff. And the reimbursement is going to be less than it costs me in chair time and value and engagement. And then at that point, I'm not enjoying doing it. What's the point of doing it? It's just, to me, it's like the worst possible idea. And I cannot for the life of me figure out why people want vision plans to be involved. I can't conceive of it unless they're afraid or unless they're lazy and don't want to put the time into creating their own fees. I'm completely confused on why you'd ever want them involved.
Really well said, Matthew. And you know, to jump on there, when this has come up, one of the common questions we'll see, and it's okay if people have this question, you know, it takes doing this specialty to understand what's involved to do it and do it well, right? So if you have a basic curiosity question, fine, no big deal. But the question that comes up is, what codes can I use to get it covered? It's like, well, no, the beauty of it is that there's not a code because it's not covered, nor should it be covered. Even if you're using a device like an orthokeratology retainer that is similar in some ways to a contact lens, it is not a contact lens evaluation. It is not a contact lens fitting or whatever you call it in your office, because a contact lens, you take their prescription and you put it in the lens and you place it on the eye and they see. This reshapes their cornea. It is a completely different process. It takes a lot more expertise and skill. And to Matthew's point, if it were covered reasonably well, eventually when it got to a point it was no longer covered reasonably well, we couldn't spend the time with our patients to do what we do very well every single day. And we're going to have to plow through them and give less care and have less visits and shorten the visit time and not answer the questions that all these parents have, loads and loads of questions, and they're entitled to ask them and get a logical, good explanation for their questions.
My only opposition to the animosity to the vision plan coming in, because I think it's a good question for for doctors that are starting. They're just getting started. They may not know. So it may limit their questions in the future. Like, oh, I'm too scared to answer another question or ask another question later on. So be gentle, Matthew. Be gentle.
Excuse my energy. I certainly would never quash the views of someone who's becoming involved, and I of course would come across with a cogent argument and a calm argument. It's just sometimes I see people have been doing this for a while who want to be, get involved, and it just really seems like a slippery slope to me. It seems like a zero-sum operation, race to the bottom.
Done. Yeah, I agree. Ding ding. All right, we're going to move on to the next topic here. The next topic is peripheral defocus contact lenses versus soft multifocal contact lenses versus myopia management contact lenses. Is there a clear winner here in your opinion? Is there something that's better than the others or has worked better in your experience? Matthew, we're going to start with you. And before I hit the timer, if you don't mind, because there's going to be people with all different levels of experience, can you briefly explain the three options and how you look at them as differently, and then tell us what you really like?
When you say the three options, are you referencing the three descriptors there?
Right, exactly. The three descriptors.
Okay, so I am a peripheral defocus contact lens guy because it describes exactly what it does. When we talk about myopia management, when we talk about myopia control, we're talking about peripheral defocus theory that has been advanced and studied and researched. And so that to me makes logical sense. A peripheral defocus contact lens to me is much more descriptive of what we're actually using. You can use a soft multifocal. That soft multifocal is simply changing the peripheral defocus within the bounds of that lens, okay? I think myopia management contact lenses works well too, but if you have someone who's only using the term soft multifocal, I think that comes down to the same thing that an Ortho-K lens versus an Ortho-K retainer. This is not simply a soft multifocal. I am trying to achieve something special with this lens that is different than just grabbing a contact lens off the shelf, right? I am looking at this patient as a patient who needs peripheral defocus in order to slow down their myopia. That's the terminology I use, and I personally really like it. I just get a little frustrated with the soft multifocal terminology.
I like peripheral defocus. I'm glad when that came out with my sites, I guess, clinical data of how they mentioned it. I do mostly Ortho-K, but I do a little bit of peripheral defocus contact lenses. And if I'm going to do one, if the parameters allow, I'm going to use a design that's FDA approved. Now, I don't use at all any of the traditional soft multifocal contact lenses. Now, a lot of them have been studied, and then they do show that they would, slow myopia progression to a certain extent, but nothing like the other peripheral defocus contact lens that have been shown. So I don't use those at all. I use the FDA approved lenses, and sometimes I'll use an off-label lens if Ortho-K was not an option for whatever reason, and there's high astigmatism. I'll use maybe a customized soft contact lens or scleral lens or hybrid lens, something that's off-label, letting parents and patients know that that is an off-label modality. But I think just grabbing a lens out of your trial set and then putting that on diminishes the value. It's the equivalent of calling an Ortho-K lens a lens.
I got it.
Instead of a retainer.
So
So I think
I'll
it needs
jump
to be
in.
something more customized. Yeah.
Similarly, I don't like calling them soft, multifocal lenses. I do call them myopia management lenses. I think some of that is maybe a little bit semantic, but simply because while peripheral defocus lenses is a very, very accurate descriptor for what they're doing, parents don't know what peripheral defocus is. So it launches into maybe a little more explanation than what I want to get into.
Oh, great questions. Sorry to interrupt you, but I'm gonna do it anyway. I don't call them
I
peripheral.
won't pardon the interruption, Annette. That's okay.
I don't call them peripheral defocus lenses necessarily to parents and patients. I'll say, these are the options. There's a drop, there's Ortho-K, and there's a daytime lens that helps also. I call it a
Gotcha.
daytime lens.
Okay, so that makes sense. I do think among us colleagues, that's a nice way to label it because it is descriptive of what it does. I use the term myopia management contact lenses. It's well accepted by patients. The other thing I will mention on your point that when you talk about a regular, soft multifocal contact lens that is being purposed for myopia management, there's two reasons why I wouldn't use that. One is, to your point, they haven't really been shown to work as well. But I'll tell you, even if they did do a study and it showed it worked every bit as well, they've already been established as a commodity, and when we're trying to get away from commodities, the same reason why we don't want to call Ortho-K molds or retainers a lens or a contact lens. I don't want it to be something that their mother already uses for her contact lenses for multifocal, because I do think it takes all that value away. So something that is going to work equivalently well or hopefully better, that is designed specifically for that. And the FDA approval matters too. It doesn't necessarily mean it works better, although in some cases the FDA approved option may work better. It's going to matter to some parents, and I think we owe it to parents to let them know if there is an FDA approved option for any mode of treatment that we offer them.
I think the studies corroborate that as well, that the FDA approved modality has shown higher percentage of myopia, slowing of myopia progression compared to the studies that showed the traditional soft multifocal contact lenses that go up to about a +2 or +250 ad, where we know the other ones go much higher than that.
Yeah, and I agree with you that they have been shown to work better. I guess my point was, even if they were to come up with a new study that shows they work equivalently.
Yeah, I got you.
Yeah, and anyway. So moving on, the next one, we got 2 minutes on the clock. Staff or doctor for doing topography, and we'll say specifically those initial topographies for your design. Anith, you get to start us off on this one.
My staff does it. I am all about delegation. I know a lot of doctors say, hey, the baseline topography is the most important, so I want to do it myself. And I 100% agree, it is the most important. That does not mean that I am the best. I haven't touched my topographer in years. Who says that I'm better at getting images than my staff? They do it all day, every day. They are much better than me. That is not something that a doctor needs to do. There's nothing that we learned in optometry school that makes me better than my staff to do it. And that it's just practice. It's just doing it over and over again. And sometimes it takes 2 people to do it. Now, I will say, I make them do it till they get good ones, and they can vouch for that. Like, I'll repeat. I mean, sometimes it takes 10 images, but taking topography is not my job. Designing retainers, clinical interpretation, troubleshooting, clinical thinking, those are things that are my job. Capturing an image is not, in my opinion.
Matthew, what you got?
Okay, I have my staff do it. So I have my staff do it, I review it, and then if I don't like it, I make them do it again. My staff's really good at it. I actually have high school technicians, which is crazy, and they're really good at it. It's fantastic. If you train a person right, if you have them be really diligent, I have really great results. Sometimes they'll show me a topography and I'm like, the lid's in the way, let's go back and do it again. We have to get, we did one this afternoon, Q-tips to hold the eyes open to get initial topography. You know, sometimes that happens, but as a general rule, they're better at it than I am because they do it all day, every day.
I get you. I feel the same way. I delegate that to my techs as well. It is super important, but we delegate taking OCTs. They're also super important. We delegate getting an Optimap or a retinal photo image. They're also super important. And for all of those things, if we don't like the image we get, we make them repeat it. I think all those points are valid, and I agree 100% on that.
And I will go in there. I will go in there and take them myself if I don't think it's a good enough one. But that's pretty rare for me. And I make them take. If it's the first day on an evaluation, I make them take 5 or 6 for each eye.
I used to do that maybe a couple of years ago, and then I realized, well, I'm not as good as them anymore. So, like, they come in I think 2 years ago, they came in and said, hey, I can't get a good image. And then I said, what makes you think I'm better than you? Like, you're the one doing it all the time. So they realize that they're the experts on this, not me.
All right, ding, ding. So our next topic is favorite atropine dosage. We got our kind of big 3 most common ones from the LAMP study, 0.01, 0.025, and 0.05, or maybe you got another concentration that you're getting somebody to compound for you. Matthew, it is your turn to start us off. What's your favorite atropine dosage, buddy?
I'm reaching for 0.05 more and more and more these days. I was a 0.025 guy, but sometimes I just don't get the oomph I need. So I'm starting with 0.05, and unless I have patient complaints, that's where I'm sticking most of the time. I do PM dosing right before bed. I put them into a transition lens, often with a progressive bifocal in there, and I get good results and happy people. So until it becomes a problem where they're complaining about light sensitivity, and until it becomes a problem where it's an issue, then I'm starting with 0.05 because that's not always. I have a lot of atropine patients, but it's not necessarily my first choice. I'm an Ortho-K peripheral defocus contact lens guy. So by the time I'm adding atropine, I need atropine on board.
Well, and if you already told us you don't do a ton of atropine for them, or at least it's usually combination, but which one are you grabbing for if you do start them off with atropine?
Before I jump into this, I know we've been to a few topics. I know we've agreed on a lot, but I think I'm still in the lead. I think I'm beating Matthew and Dwight in this debate. I'm the leader. I think so, if I can claim that. But I will take a little bit of dissension from Matthew here. Okay, I go for 0.05. I always been. I'm going straight to 0.05 if I'm using atropine, whether it's combo therapy or not. Never had any issues with it. The kickback, I was, I don't know about this progressive lens nonsense that you're going with, right? I don't know I don't know if it's worth adding. Sometimes I'll prescribe an anti-fatigue if the child is having some issues, but really, from my experience, most kids, even if they go up to 1%, they're usually pretty good. I do agree with the transitions. I love having that on board. So my favorite dose is start 0.05, put him in some photochromic lenses. I'll throw in an anti-fatigue if I notice, because then you can put a drop in and see, at the 1 week follow-up or whatever it is, and see if they're having any problems at reading. And that's it. I don't know that the progressive lens itself is doing anything for myopia control. And if you're concerned about near reading, I find that with 0.05, you haven't needed as much.
I got the habit of it because I had some concerns from patients about the near component. And when I said progressive, I really meant like a relax or a boost lens.
Got it.
I was probably misspeaking a little bit.
Gotcha. Okay. So I'm very much in line with that too. If we're going, especially if we're going atropine monotherapy, 0.05 is what I'm grabbing because the data backs it up, or at least the most powerful data out there that we've had access to for a little while does. I'm the same way. I don't do a true progressive lens unless we've got a patient who is complaining. I pretty much, as a matter of course, put them in some type of a boost, anti-fatigue type lens, like you guys said. Whether they have complaints or not, it's easy enough. I put a lot of kids in those types of lenses anyway.
Me too.
They tend to do well with them. And certainly photochromic transitions, light adaptive, whichever term you like to use for that. I'm a big fan of that as well. I will sometimes go a little lower if we're doing it in combination with something else. I will grab a lower dosage sometimes if if I think we just need a little bit more of a boost for someone doing orthokeratology, for example. But in general, if it's atropine by itself, 0.05 these days is what I'm grabbing as
There
well.
was something that came out today on
Thank
some of our
you.
little email
Yeah.
groups
You're
about
comparing
Yes.
0.01 to 0.02, right?
about 0.01% versus 0.02, which just for those that don't know, 0.01% was shown, I think, in LAMP 2, where while in previous in LAMP 1, it showed great myopic control by refractive error, not so much in axial length in LAMP 2. So now in the last several years, most of us myopia control doctors not using 0.01 that much. And this particular Medscape article was interesting. It showed, but kind of confusingly, and you guys can chime in on here because I'm not a big science guy either. It kind of hurt my brain a little bit. It kind of interchanged 0.02 versus 0.01 in the conclusions, and it ended up basically sounding like 0.01 was more effective in 0.02. It was very interesting and very confusing. From my perspective, I thought it didn't do a good job of the study design. It didn't influence my clinical criteria of what I'm going to prescribe. I'm still going 0.05, but did it influence you guys? What were your thoughts on that study?
Okay, so I didn't get a chance to read it, but I did see some of the feedback there. It was just too busy in clinic today to get a chance to check it over. But someone had indicated that there were some questions about who sponsored the study, where the money was going, and that is always my concern. Those of us who lecture, when we're on stage, we're always supposed to be giving you a unfettered truth view of things. And when you have a study, and I haven't read the study, but if you have a study that's questionably funded, you have to question the results. And that's what people who had already read it seem to indicate. So I'm already going in a little cynical.
Sure. And I'll throw one other thing in there. And I have not read that article yet either. As Anith said, it came out today, and I had a busy day, and I kind of bookmarked that email to go back to. But one thing I will mention is, there was when you look at the ATOM study and then you look at the LAMP study, the performance of 0.01 atropine was fairly different between those two studies. And it's the same concentration, which is an interesting thing when you look at it because they were both relatively big studies. So, we look at the LAMP study, and that's one of the big reasons why there's been this push from 0.01 to the higher dosages, and 0.05 becoming a lot more common these days. But I think what that possibly does illustrate as well is that, when we're talking compounded medications, we don't prescribe as many of those, obviously, as we do the more commercially available concentrations that are out there. There are different ways of creating a compounded medication, of diluting that down, right? You can reconstitute it from a powder, you can dilute it with saline, and of course they're doing this under sterile conditions. And that's been kind of a little bit of one of the arguments there as to why those two studies, which were both relatively large, would get different outcomes from the same concentration. That they weren't just a little different, they were way different. So it's worth mentioning there is a company that's working on a commercially available 0.01 atropine that you could, just get at a CVS or what have you. I'll be curious what their studies show, because most people are gravitating toward those higher concentrations. They chose 0.01. That's what they are working on. That's what they're doing FDA trials. I'll be curious to see when everything's all said and done, what type of myopia control they end up getting with that.
That's an interesting point you brought up, Dwight. I went through the study. I read kind of the abstract and some of the conclusions, and briefly through the methodology of it. What's interesting is, though, your point of compounding. And there was a study that showed how compounding atropine has very different efficacies and whatever percentage comes out there. With something that's commercially available and it can be more repeatable, it'd be very fascinating to find if 0.01, that's repeatedly 0.01, actually performs well. And the problem with the previous studies were the compounding nature of it. That'll be fascinating to find.
Yeah,
and
it's an interesting thing. So we can watch that. I think we're all going to be pretty interested when those FDA results get published.
Right. Yeah, Matthew, right. I did see that somebody commented about the company that's coming out with the commercially in 0.01 and that they're sponsoring that study. I didn't see that on the disclosure. I just saw it on the email. So that's you always got to be worried about that kind of stuff. But yeah, the compounding issue is another problem. Putting us in this dilemma.
Ding, ding, ding.
All
We're
right.
going to move on. We gave that one a good 4 or 5 minutes, I think, but I think we had some good banter back there on that. I think that's a lot of good information that's very relevant with what's coming out. We're going to move on to the next topic. The next one is, we always talk lifestyle environment for patients. Best tip from a lifestyle perspective for kids related to myopia management. Aneth, you want to jump in on this?
Yeah. Number one, don't get born to nearsighted parents. That'd be great if you can avoid that.
Good advice.
Number two, if you're not myopic, don't stare on a screen all day long. Get outside, play, get some sunlight, look outside. We don't know which of those reasons are protective against myopia, maybe both, but that helps. Enjoy recess. As much as you can avoid the environmental factors, which we know are likely to cause myopia progression, which is near work. So delaying screen time, reducing screen time, taking breaks from screens, which is so predominant for kids these days. I mean, it's crazy. I mean, when they go to school, that's all it is. So some of it you can't avoid. I mean, they're going to be, unfortunately, in front of a screen for 6 hours a day from school itself. So taking breaks will be a big help. So the big thing is don't get born to myopic parents. Be outside as much as you can, and reduce the screen time as much as you can.
Matthew, what you got?
All right, so I'm going to boil it down real simple. Every time I have a myopia management child in the chair, and I just like you guys, I get a lot of them, I ask them this: do you use your phone in bed? Yes, I do. I spend an hour on my phone or 2 hours on my phone before I go to sleep. And I tell the parents, I'm like, you need to take the phone away when that child is getting ready for bed. Because in my opinion, that phone in bed, when they're laying there like this, staring at their phone in the dark with the blue light from the phone, terrible. I tell parents, if we do nothing else today, get that phone out of their hands at bedtime, pick them outside.
These are kids that are saying they do that all the time?
What's that now?
These are kids that are saying before bed, an hour before.
Ask. Absolutely. Ask any kid over 12 years old.
Wow. I need to ask this because I don't do that. I go to sleep. I got to start asking that. I'm missing the boat.
You're going to be blown away.
Wow.
I bet it's 90% of my myopia management kids.
Oh my gosh. No. That's
all right.
foreign to me. I
That's
never.
ding, ding, ding. I will echo some of that. Matthew, that's a really good point. I don't think I do as well of a job as I could asking specifically about that habit. And we are married to our phones as a society, and kids, it shouldn't be a shock that kids are as well. One of the things that I'll tell them, when you get parents that are rightfully concerned because they've got a child who's already nearsighted and both parents are nearsighted and the older sibling's nearsighted, and they've got high prescriptions in the family, and they're coming in very, very concerned to start with. They do have some apprehension over the fact that, like, school uses computers. They're going to be on devices, whether it's a computer or at the classroom or when they get home doing their homework. And one of the things that I do is try to at least acknowledge that. I'll say, hey, look, we've got, you can think of it as all the near work, especially the digital screens, kind of pulling the eye in one direction, and outdoor time potentially pulling it in another direction. And I know they've shown more benefit for kids that are not nearsighted yet, but outdoor time can't hurt, right? And I'll tell them to think about it that way. And so if they've got the amount of schoolwork they have to do on a computer, you don't have a choice for that. So try not to stress over it. They need to use it, build in some appropriate limits and break it up and encourage them to take breaks. But when they're going to use it for recreation, track that, put common sense limits, and try to balance it out with an equal amount of time spent outside. And at least that lets them feel like they can allow their child to play a video game, which isn't the worst thing in the world with all things in moderation, right? But then they can say, great, well, you played that for an hour, so go get outside and kick the soccer ball around with your brother, or ride your bike, or whatever, go fishing, or whatever you're going to do. And you need to earn back that additional recreational screen time.
And if you're playing video games, then put it at least on the screen. Like, don't put it on the tablet right in front.
Yeah, no doubt. Cool, ding, ding. So our next one is, it's interesting. It seems like it's gotten a lot of buzz, at least in the Ortho-K Google group over the last little bit, but we're talking translimbal orthokeratology. So those larger diameter lenses that extend past the limbus as opposed to trying to cover, 93, 95% of it. Matthew, you got any thoughts on translimbal Ortho-K?
Yeah, I have a fair amount of thoughts on this one. I think I just think I think it's an interesting discussion. It's a term I originally came up with actually about 15 years ago, and I just want to get that on record. No, I'm kidding. I
Disagree with you on
absolutely.
that, by the way. Come up with
If
that.
we can timestamp that, let the record show that Matthew created that term.
Yes. Yeah.
Actually, I have never fit a translimbal ortho-K lens. I have colleagues that do, and I'm really quite interested in the concept of it. Apparently, the idea being that you're going to vault it in such a way where it doesn't rest on the limbus. My fear, of course, is that limbal integrity. You know, when we're fitting scleral lenses, we're always worried about those limbal stem cells. And I'm very interested, though, because occasionally I run across patients, I just can't get the center. I love the idea of trying it. Have either of you two ever tried it?
All right, let me jump in. So you're going to get some texts and calls and emails that you invented translimbal. Apparently, like 4 or 5 doctors think that they invented that term. I don't know who it is. All right, before my time, I have done it. And one thing I want to say: this is not a scleral ortho-K. That's very different. You are not designing a scleral lens. You're not fitting the sclera. All you're doing is making a larger diameter ortho-K where you're getting past the cornea. And I've done it a couple times, and I have to lean on my colleagues who've done it a lot more than me to kind of learn about it. I am super intrigued by it. I am very much more open to trying it more often, to be honest. It does center better. If you're doing complicated cases like hyperopia and presbyopia, you know, for adults, I think that's the way to go. But I'm still, if I can get a corneal design to do it, why not just stick with that? That's where I am. And if the corneal design doesn't work, then maybe I'll go with the translimbal design. And the idea is that you have more plastic, right? You have more plastic to get the desired result. You're just doing the same ortho-K design, just increasing the diameter. So you have more of the retainer to use to manipulate the cornea the way you want to. And that can be very helpful for, say, high myopes, adults, emmetropes that are presbyopic, hyperopes, which we all know are very difficult. I think it can be very helpful in those cases. Sure. The problem is, you know, there's only a few doctors that have so much experience in it. You know, probably 5 to 10 docs. You guys can correct me if I'm wrong. That have done more than 100 cases. You know,
yeah, and that's ding ding. That's ding ding, but I'm going to jump in real quick on that as well. And just like you guys, I don't have a ton of experience. I will tell you, I have exactly one patient wearing a translimbal ortho-K design. So far from an expert on that. You mentioned that the number of people who claim to have invented translimbal ortho-K, and the thought that comes to mind is when you talk about like a big sporting event, like Don Larsen's perfect game in the World Series, or Wilt scoring 100 points, or Babe Ruth's called shot. You'll have all these people who claim to have been in the stadium that day, but you know the stadium doesn't hold that many people. I wonder if it's something like that. But to your point, there's not that many people fitting a lot of them, and probably it was one of those guys that you see from time to time that fit a lot of them that did, or maybe it was simultaneously a couple of guys starting to do it. I don't have a lot of experience. I do think the one interesting concept that comes from these discussions is it fine for that to be just your first choice for everyone, or should it be reserved for certain specific situations? And there was quite a debate going on recently through that email thread about that. I guess my thought would be if I were fitting more of them and I found that it was performing in a superior way to my standard diameters covering about 95% of the cornea, I would have no problem making it my go-to for all patients. I don't have that kind of experience to say that. And when I listen to these guys, I don't get the sense that they're in generally finding that it is necessary or performing superior for your more typical patient. So I don't have a real concern with making that your go-to, but I haven't felt the need to do that.
I will say this, there, outside of you guys, which I, listen to all the time and always look for advice. There are 2 other doctors that were probably in this discussion that you're talking about. One who is very much corneal and one is very much translimbal. And I've reached out to them for mentorship over the course of the years and have been very beneficial for me, for my career. even from the doc that is pro translimbal, has mentioned that, it's not necessary in all cases. He finds that it's very successful when he needs to use it. He's not hesitant to use it. And I even gone to him cases where I thought, hey, this design isn't working. What's going on? Should I go translimbal? He's like, translimbal is not the problem. You got to do this and that. So I would still say, I don't think it's a first line therapy yet. I think corneal designs are still so good. There's no reason to jump into translimbal for every case, especially with myopia control for kids. I think it's still another tool in our toolbox for those complicated cases.
It does make me wonder though, with like the Eaglet eye profiler and some of the new stuff they're coming out with, those things are doing a better job, right, of mapping those areas than we've been able to do previous. So that kind of opens a lot of doors.
I'm doing some testing with them, and there's another doctor that does a lot of translimbal designs with Eaglet as well. It's a lot of success. I guess my issue with that is, well, how much of the scleral data important if you're not fitting the sclera, right?
Yeah, okay.
What we find out is the Eaglet also maps, depending on your topographer, it goes out further, even in the corneal data, and then you can have a more appropriate edge lift anyway. So more stuff to come with that. Hopefully in the next few months, maybe by Vision by Design, I'll have some info on you for that.
I'd love that. We can talk about it over a drink.
There you go.
All right, ding, ding, guys. We got one topic left before we wrap it up. It's a big one, and I put 10 minutes on the board here, okay? Transferring care from one provider to another, and I'm going to give you a little background information. I might as well go ahead and start the timer because we're probably going to go over anyway. But here's the idea. When we transfer care for non-ortho-K patients, when it's just somebody moving from one doctor to another, there's been a big push for portability of healthcare, and you get your records, and they do a records release, and you send it. Is it the same with ortho-K? What information, if any, should the initial provider be required to send? Where do you draw the line between the patient access to medical records and an intellectual property of the initial orthokeratology provider who has designed something they spent a lot of time into and required their expertise to do so? What needs to be sent? What doesn't? What should we do? What should we not do? Aneth, go ahead and start us off.
All right, so I've been through this for a few cases with doctors in the state of Texas. I had to deal with this for specialty contacts, which also get into the ortho-K realm. So what you're required to provide, at least in our state, you have to provide medical records, no doubt. Medical records have to be provided. Your design of lenses, if they're specialty lenses like RGP, sclerals, etc., and that can lead into ortho-K, can be considered proprietary. Like you put in the work to design them. That is not necessarily be shareable because you put in the work to design them. Okay, so you don't necessarily have to share it. This went to our TOMCHI board and a lot of reviews, and that's what came out as the outcome. Here's my view. If my patient goes to Iowa, Wyoming, New York, California, your practices, I'm going to give you everything. I don't want to be in the way. This is an ortho-K patient that was with me, and I've done everything I can. They just moved. So what? I don't want the other doctor to have any problems. That includes my software-based designs, which, as you guys know, takes a lot of time. I know a lot of doctors like, everything I put into this, I designed, I did all the work. Now I'm just giving you that? Like, what if it took me 5 designs? What if it took me 10 designs to get there? I did all the sweat, blood, and tears, all the legwork to get there. Now I'm going to give you all of this? Yeah.
Gotcha. Matthew, you want to jump in on that?
I'm going to do it.
Yeah, I have, again, strong opinions. It turns out I'm more opinionated than I thought. So I am in a practice, a lot of patients are moving out of my area. So we have a lot of people that move from my fairly rural practice to big cities, right? Detroit, Grand Rapids, larger cities around Michigan and in the country. So I tend to share a lot of information with the fellow doctor. What it boils down to for me is as soon as I know who the patient is going to see, I reach out to that doctor and I tell them, I am transferring this patient to you. Here is a complete letter, axial lengths. This is the design I'm using. This is what I've decided to do. This is where my success is at. Here's original topographies. I want to help the other doctor if at all possible. Now, some doctors just aren't receptive to that. And what I run into is a lot of times they'll throw my design out the door and then wash the patient out and try to design their own, which inevitably leads to unhappy patients. So for me, as long as the other doctor is willing to work with me, I am more than happy to share any information that's going to help my patient, because ultimately that's what needs to happen. And then if I'm going to share that information, I let the patient know I am giving this next doctor all the information they need to simply take over the care. That I'm setting you up, so this is going to be as smooth as possible transition for you. And I find that lets me sleep better at night. I want the other doctor to have the information, and I don't typically mind giving it up, especially if it's going to benefit my patient. I have the best patients in the world, and I want them to be happy wherever they go, because oftentimes they'll come back and see me. Go to the other doctor, I didn't like their office, I didn't like their staff, I'm coming back to see my family at Christmas, can I see Dr. Martin again? So it's not uncommon for me to have to deal with that, and I think the more forthcoming we can be, the better. And I always try to find an academy doctor, an ortho academy doctor in whatever area they're going to, so I can transfer care.
Yeah, that makes sense. So, and I follow along the same lines with you guys there. I think part of the big question, and maybe this is more philosophical, is what should the initial doctor be required to send versus what should they just send because it's the right thing to do for the patient? I think a lot of times that comes down to, and you guys alluded to it a little bit, patients moving out of your area. Is the patient moving across the street, or are they moving across the country? Because if they're moving across the country, like you guys, I feel like I owe them everything that I can to make it as seamless as possible. I don't really want to see them have to be washed out unnecessarily, which is not only going to be inconvenient for the patient, it's also going to cost them more money. If a patient comes to me transferring care and I'm going to wash them out, and frequently I need to do that, it is a different level for fees. It's just more of my time. It's going to be more follow-ups. Whereas if they've got a design that's working outstandingly well, and I am able to foster that relationship with the previous doctor and kind of take over, I don't want to put them through that. I don't mind charging them more if it's for my time, but if I can keep them wearing the same mold, not have them have to have that inconvenience of a couple weeks washout or maybe more, I like to do that for them. If a patient's moving to my competitor across the street, I'm going to show the records. Obviously, that's the patient's property. And I think legally there are some certain parameters of a standard rigid contact lens that you would have to share. But I think it boils down to just base curve, diameter, and power pretty much, which certainly isn't enough to fit a complex ortho-K design. If they're moving out of the area and need be, I'll guide another doctor through it. If I'm talking to somebody who hasn't fit, a more complex design that I'm fitting, I don't mind just sending them the information and then setting up a phone call and guiding them through it. And I had people do that for me when I was just starting off, and I really appreciated it. I learned a lot from these docs who had been doing it longer. And if I can do that for another doc and guide them through it, and at the same time help the patient have a better outcome and an easier transition of care to another doctor, I'm all for that.
I think you make a very valid point. I think it comes down to the relationship with either who I'm transferring to or who is transferring to me. And I think if we're all polite and pleasant and intelligent, then it's smooth as silk. I get frustrated when I send a patient out and I send all the information, and then the other doctor washes the patient out and they're miserable for 3 or 4 months till the other doctor figures it out. That frustrates me for the patient. It frustrates me for the fact that it could have been smoother.
Yeah, absolutely.
To me, it's different. Like I'll send everything I have, regardless if they're a foot away or 1,000 miles away. I don't think anybody has really competitors. Now, as far as the washout, I think it's got to be up to the practitioner. And a lot of times it's a phone call, like you guys mentioned, right? Like they'll call, hey, I got this patient from you. They happen to move here. This happened last week. Like, hey, these are my fees. They might be different than yours. I'm like, listen, they're your patient now, right? If I'm going to give you everything I have, and if they're doing great and you're comfortable, like, hey, this is working well, and you got to reorder retainers, charge the fee for that. If you think, listen, we got to start from scratch and this is what the fee is going to be, that's what it's going to be. I mean, you're in another state, like that's your doctor now. And they're doing, to me, and you guys can correct me if I'm wrong, most optometrists, I mean, our hearts are so big there's very few optometrists I've run into that are going to screw a patient over, really, to be honest. I mean, to a fault, we give away our fees more than anything else. So I've never come across a situation where I had a colleague that was trying to do harm to a patient. It's never really happened. So I think, it's okay if you want to wash them out and you think that's best for the patient. Look, they're in your hands now, and I trust you for that, but I'll give you everything you need from my end.
And I have had that conversation with former patients where you're like, well, you've been seeing this new doctor. They're the one that's handling your care. I can't get involved now. You've been gone from me for a year. Unless you're coming back, I'm not going to Monday morning quarterback that other doctor,
Sure.
Yeah, I've had that, you, for example, you had patients that came over to Texas and you recommended us. I appreciate that. Thank you. And, I always tell them, you're so lucky that you got a better doctor now than when you had met.
I'm going to go slightly off topic, but I think it relates to transferring care. I think one of the big take homes, and I had to learn this the hard way early on when I was fitting patients, and I hear stories from other doctors. You need to charge appropriately for someone who comes into your care because you never know what it's going to turn into. It might look straightforward and it might turn out to be very, very complicated. And so early on, I was happy to get a patient. I was like, oh, I'll take over care and I won't charge that much. And, you do have to charge appropriately for your time because we do spend time with these patients. And for anybody who hasn't been doing this that long and you're trying to structure your fees, watch what you're charging for somebody who comes in who is not currently your patient. And I think, Dr. Carolyn Kalki does a great job of that when she goes through the boot camp program, in that this can really turn into a nightmare. And the last thing you want to do is, you mentioned, Matthew, not wanting to nickel and dime patients. Be in a situation where you say, oh my gosh, I've already put way more into this than what I got from the patient in fees. And we're not even there yet because it was a washout. It was a really complex thing. And, sometimes when you move, you're going to switch doctors and you got to end up paying a little bit more, at least at that first visit. And you got to charge appropriately for the time you're going to put in to take care of that patient.
I think there's nothing better than going through the AOMC doctor locator. I mean,
absolutely.
That is the best tool to use. And, I'm joking about Matthew, obviously. His patient that came to me, I was very lucky that he even thought of me, and they're doing fantastic already. But the best thing you can do is just be upfront. Look, if you're doing well, this is what it is. This is the cost. And if I need to start from scratch, unfortunately, there's more work, and this is the fee. And just be upfront with it. That way they know. I mean, there's no reason to tippy toe around it. And that's what I've done with patients. This has happened recently where I had a patient that, to be honest, a lot of times these patients that are already in ortho-K that come in sometimes can be more of a headache, especially if they're dying. So I'll tell them, look, let me see how you're doing. If you're doing well, great. Simple. If I have the parameters, I can reorder. If it's not doing well, we're going to have to start from scratch, and there's no other way about it. And just so you know, and that happened where a patient that came in, she was seeing okay. She had some residual still, -0.5 here or there, but she wasn't complaining. But no complaints, no ocular health issues. Axial length was well controlled. I was like, listen, I could probably redesign you in a custom software-based design and get rid of that -75 still. I've been noticing it. I talked myself out of several thousands of dollars, but I did what's best for the patient. They're doing fine. What am I redesigning for when the main goal of myopia control is in effect, health is in effect, and the patient is happy?
I think you're 100% correct.
Yeah, completely agree. Well, we were in agreement on that last one. Look at that. That wasn't much of a debate at all, but it is a really good topic to cover. And that takes us to the end of it. We went over a little bit, but man, we covered a lot of important stuff there, guys.
That was so much fun. It really flew by for me. And, maybe that's because I was winning most of the topics.
Oh my Lord, you're kidding me.
Dwight, if you have a spiral.
You made like 2 points the whole time, 2 points.
I'm just over here licking my wounds.
That was great. I really hope everybody enjoyed it. That was so much fun.
Absolutely. I would like to do this again because as we were going, I thought of at least 4 or 5 or 6 different topics just as we were going that we could easily do this again sometime, because this has brought up other stuff that we could easily do that wouldn't repeat any of these things that are like little tips and tricks and things are controversial and would be fun to talk about.
I think Dwight will agree. Anytime you want another beatdown, we're fine for it.
Coming out with the bell ringing and the boxing gloves on, and
There you go.
we'll go a few rounds.
Hey, Matthew, I want to thank you so much for doing this again. I mean, twice. I mean, I really appreciate it. It was so much fun. Dwight, great job of putting all the questions together.
That was really well done.
Yeah, that was fantastic. I want to thank everybody who watched today. I mean, it was so much fun for us. We hope it was so much fun for you. Until next time for the next.
One last thing, Aneth.
Yeah, go
One
ahead.
last thing.
Yep.
Don't forget, Vision by Design is coming up in September.
Yes.
Early September. It's in the Chicago area. If you're not registered for that, you should do it. You should make sure you go to that meeting. It's the one.
It is going to be a fun time.
If you have any interest in myopia control and ortho-K, that is the meeting. I mean, if you thought this was fun, that meeting is this on steroids for sure.
Oh, yeah.
And the lectures are going to be amazing. I think both you guys are doing talks at Vision by Design, so can't miss. And then, as you guys can attest, so much of the learning happens outside the classroom too. So,
Oh my gosh, the conversation
recommend
I've had over dinner or a drink. Oh my Lord.
I mean, that's how I learned so much from you guys. Is really just outside of the classroom and how we become just such good friends, and how much I've learned from both of you. So I really appreciate that from just me personally. So anyways, cannot highly recommend Vision by Design coming up. Thank you again for listening to another episode of The Corrected View. Thank you guys. Have a good night.
Thank
Good
you.
night. All right.
I invented translimbal ortho-K.
Wait. I invented translimbal ortho-K. It was in 1982.